Hi there, my name is Eleni. I'm a fourth year speech pathology student who is currently completing the Paediatric Fluency placement at the Trobe Communication Clinic. A little bit about me. This is my second last placement before I graduate. Prior to this placement, I never had any experience in fluency, only had knowledge from my academic coursework. The aspect of the placement being wholly online was also new to me. So the placement that you will be undertaking is the Trobe Communication Clinic, or LCC Paediatric Fluency Clinic. This clinic is currently being delivered online due to COVID-19 restrictions. This means that the children can still receive the treatment, and both us and the kids are all really safe. We all have prior knowledge of stuttering from our coursework, but I think it's really important to brush up on your stuttering knowledge and your knowledge of the Lidcombe Program before beginning this clinic. By being well versed in the theory, you can focus all your energy on your clinical performance. So stuttering is classed as a communication difficulty that causes involuntary interruptions in the flow and rhythm of speech. Hesitations or interruptions to speech are natural and is what is known as normal disfluency. But stuttering is defined as when the interruptions and disfluency in speech noticeably disrupt the flow of conversation and impact the message the person is attempting to convey. Onset can be gradual or sudden. The typical age that stuttering presents is anywhere between 2 to 4. Often the caseload that you will be working with is older than that, so something to consider is that you're working with both parents and children who are really motivated. Stuttering varies between children of its frequency and severity. This is important to remember in clinic. We'll talk about different types of stutters, but remember you need to look really closely at behaviours and understand that sometimes stuttering can be quite subtle. So there are two main categories of stuttering behaviours: unambiguous stuttering behaviours and ambiguous stuttering behaviours. Unambiguous stuttering behaviours include repeated movements. This includes a repetition of a sound, syllable, word, or phrase. For example, a repeated movement at the sound level may sound like this: I love cake. The other unambiguous stuttering behaviour is fixed postures. These occur when a child gets stuck on a sound in the word. Fixed postures with audible airflow, also known as prolongations, may sound like the person is stretching out a sound at the beginning of or within a word. A fixed posture with audible airflow may sound like this: snake. Fixed postures without audible airflow are also known as blocks. They may appear as the person is struggling to get a word out, and they often present at the beginning of a word. A fixed posture without audible airflow may sound like this: oh. Ambiguous stuttering behaviours are commonly known as superfluous behaviours. They occur alongside repeated movements and fixed postures. They would not be present if the person was not stuttering. Verbal behaviours include interjections, for example, oh well, We all use fillers like and like in typical speech, so the frequency of this behaviour needs to be considered in relation to its impact on the message. Associated nonverbal characteristics can develop when a person who stutters become aware of their non-fluent speech. These include eye blinking, facial grimaces, avoidance of eye contact, avoidance of speaking situations, and body tension and movement. If this behaviour occurs during an unambiguous stutter, the speech is most likely to be stuttered. Stuttering isn't always very clear. The Lidcombe program has been focused on in our coursework, but again, it's really important to understand the theory. Remember, parents are taking time out to help their children. You must respect their time and effort that they're putting into this program by being well versed in the theory and having the ability to answer their questions. The Lidcombe program is an evidence-based behavioural treatment which uses the principles of operant conditioning. Operant conditioning rewards good behaviour with praise and attention and is more likely to be learned as compared to a behaviour that is not met with a response or met with punishment. The Lidcombe program encourages parents to reward their children with praise and attention for stutter-free speech. There are currently a number of approaches to stuttering therapy, but the Lidcombe program has the strongest evidence to support its use for preschool-age children and some evidence for school-age children. Although the research evidence for the Lidcombe program is for school-age children is not as strong as that for preschool-age children, the clinic has seen some school-age children's success stories. We make some adaptations to the method we approach therapy for school-age children. So, verbal contingencies. This is the most important part of the program. Parents must have the ability to correctly identify stutter-free moments and deliver appropriate verbal feedback. This is especially important in stage 1 clients, as you will spend some time working with parents to identify stuttered and stutter-free moments to decide when to deliver correct feedback. We call this feedback parent verbal contingencies, or VCs. There are 3 types of VCs for stutter-free speech. Praise, wow, that was so smooth. Acknowledge, which is a bit more matter of fact, that was smooth. And request for self-evaluation, was that smooth? It's important that the answer to this question is always yes. We do not want the child to be in doubt, so you would only provide this VC when they were smooth. There are 2 types of VCs for stuttered speech. Acknowledge, again, very matter of fact, that was bumpy. And request for self-correction, that was bumpy. Can you say it again? This one is really important to understand because parents may be tempted to use the stuttered speech verbal contingencies in the early stages of stage 1. It's important you understand and explain to them why it's not done in the early stages of stage 1. It's also important that they're delivering the verbal contingencies correctly. So they only say smooth, not good or clear. It's really important that we use the word smooth. A big one is using self-evaluation correctly, only asking if it was smooth, if it definitely was. We never want the child to be in question. Remember, when in doubt, there may have been a stutter, say nothing. So just before we move on, I'd like to show you the severity ratings. This matrix is available in the LMS, and it's what we use to rate the stuttered speech severity. By looking at the different matrices, we can justify our rating, and you can use this with your parents, and you'll of course explain this to stage 1 clients. The severity rating chart is something that you'll receive before your session with the client, and you'll be able to see how your child's been tracking in the week since you saw them. So a typical stage 1 Lidcombe visit. These sessions are quite structured. You're of course responsive to the nature of your clients and their parents' answers, but you essentially work down a list and you make sure you've covered everything. So first you'll have a conversation with your client, anything to get them talking. This is where online gaming can be really important. If you play a game, it can remove some of the stress that they may feel about having a conversation with an unknown adult. Another way to elicit language is to ask questions and then follow the child's lead by asking follow-up questions. So what did you have for dinner last night? Do you normally have that? Do you like having that? What's your favorite dinner? By working with the client throughout the placement, you'll find ways to get them talking, even if it takes a while. While your client is talking, you must record what kind of stutters and what words they're stuttering on. It can be tricky to do, but this is a skill that comes with time. After you feel you are confident in assigning a severity rating to your client for that conversation you just had, you can ask your client to leave if appropriate. This is useful as it's important the client doesn't feel further self-conscious about their stuttering by adults having a conversation about it. It may be more appropriate for the client to stay and join in the discussion about the severity of the stuttering, but given it's a stage 1 and clients tend to be quite young, this is highly unlikely, so often you would ask your client to leave and go independently play. So now you have a record of the stutters and the severity rating for that conversation, and you ask the parent what rating they would give that conversation. It's really important that you ask the parent first because you don't want their judgment to be biased by your judgment. If the parent severity rating is different to yours or Paula's, pull up the stuttering severity rating matrix and discuss the different elements of the matrix. If you still can't agree, talk about the specific stutters that they heard and explain the stutters that you heard, and maybe you misheard and you're misthinking something, but it's just really important that you get a consistent rating because that ensures that the severity ratings that come in every week are more likely to be accurate. And of course we need the severity ratings to be accurate because we would hate for a child to be in stage 1 longer than they needed to when they could be progressing to stage 2 if those ratings are inaccurate. So after you have the conversation and you agree on the severity ratings, you'd move into talking about that week's practice. You talk about the activities, how fluent the client was during their sessions, the verbal contingencies. Everything is really important to discuss. The program doesn't work unless it's administered correctly, so it's your responsibility as a clinician to iron out any kinks during the session. This is also the opportunity to discuss the videos they sent through of their practice sessions, which you will receive before Thursday, and this is where you provide your feedback in relation to those videos. If you have any change to your activity, like you're introducing a new activity, which I would really recommend doing as often as possible so the client doesn't get bored of the program and wants to stop, which can often be a problem, low client motivation, you can introduce a new activity. Be thorough in your explanation of how to use the activity and how to achieve smooth speech in the most efficient way to really check that your parent has understood your explanation is to ask them to demonstrate with the client in front of you. It's also a great opportunity to provide real-time feedback to your parent about how they're administering the program. If your parent also doesn't feel confident in administering the new activity yet, you can pretend to do it with them so they can become the child and you can become the parent, so you can practice together like that. So you would finalize the session by asking the parents if they understand and if they have any questions. It's really important to ask continuously if they have any questions because the sessions are only weekly. While we do email during the week and some of you may WhatsApp to exchange videos, the best place to ask questions is during the session. So you want to give your parent the opportunity to ask any questions they may have. At the end of your session, your client will log off the Zoom and the other students will turn on their cameras and mics. After some peer and clinician feedback, you will all log off. It is then your responsibility as a student clinician to write up your clinical notes and send them through to Paula to enter into Unity, and to write up an email to the client explaining what you did today, what your expectations are for the week, and any resources you provide them with, as in a new activity. It's also a really nice opportunity to give them a reassuring message to let them know they're doing well. It can be quite tough giving negative feedback in the session that's only 45 minutes, so an email is a really nice space to reaffirm that they're doing a really great job and they're making progress. So we've just spoken about stage 1 of the Lidcombe program, which is eliminating the stuttering and building the parents' skills in how to maintain fluent speech. The second stage is the parents maintaining the fluency by using the skills and strategies that they learned in stage 1. The purpose of stage 2 is to maintain fluency rather than to implement the program. A client will only progress to stage 2 when they are fluent, and the parent is then expected to take over the problem solving to maintain fluency. And that's why we want them to think like a speech pathologist. Talk about progress will be far more general, and the stuttering should be rarely present in your client's speech. This stage can be quite variable because the time between visits tends to increase. These clients don't require the same training in the administration of the program as stage 1 clients do. These sessions are more about troubleshooting any errors and ensure the program is still being administered correctly and without difficulty. You'll begin the session with your client and their parent, or just even their parent, talking about how their progress has been since the last clinical visit and in the last few weeks. Make sure you keep your initial questions about their progress general, as the parents are well versed in the program and they will know what they need to tell you. Then you'll move into discussion about the practice session. Now you can be specific in asking how many questions, how often, when. These details really matter because eventually the program will be withdrawn, and it's really important to know the current dosage so we can work back from it eventually. Finalize the session by asking the parents if they understand, if they have any questions. Again, it's really important to ask questions continuously throughout these sessions because these sessions are so far and few between. Parents have less opportunities to ask you questions. And again, we are available over email, but a session really is the best space to ask questions. The final confirmation, it's great to ask the parent to repeat back what the action plan is for the weeks or the weeks ahead. This really means they can understand if they can say it back to you. At the end of your session, the client will log off the Zoom and the other students will turn on their cameras and mics. After some peer and clinician feedback, then you will write up your clinical notes. Again, you'll send an email through telling the parent or client what you did today and what your expectations are before the next visit. And of course, any resources that you provide them with. So to prepare for this placement, I would recommend revising your previous knowledge of the Lidcombe program and just stuttering in general. Given that a lot of this placement is working with parents, not children, it's important that you're well versed in the theory. You will receive a number of helpful documents from Paula, but also using the handouts provided to us from uni, back when we did our PBL classes, and even the stuff on the LCC Clinic LMS page can be really helpful. The Lidcombe program is heavily parent-focused. Many parents who have a child who stutters already find this stressful, and the added stress of administering the program can often be quite daunting as well. Make yourself available to answer parent queries and use this placement as a great opportunity to work on delivering feedback to parents. Often you'll have to correct parents in the identification of stutters or their lack of identification of stutters, or even the incorrect administration of verbal contingencies. There's a lot of things that can be misinterpreted over the computer, and it's imperative that the Lidcombe program is delivered correctly for the child. If a child is being praised